could start. So welcome, everybody. You may remember that last year we had announced that NEMUS had started a new phase with a key focus on supporting the knowledge sharing component of ImPreP. And ImPreP was a demonstration study of PrEP implementation in public health facilities in Brazil, Mexico, and Peru, which had started last year in mid-2017 in those 3 countries with support from UNITAID. So what is ImPreP then? ImPreP is this demonstration project that will allow for the implementation, adaptation and implementation of PrEP as part of combination prevention with MSM and trans women in public health facilities in those 3 countries, in our 3 countries, and then we provide fundamental evidence of PrEP performance that other countries will be able, we hope, to use to adapt, particularly middle-income countries such as Brazil, Mexico, and Peru with concentrated epidemics. So that's the focus of the webinar of today in English and Thursday in Portuguese and Spanish. We hope to talk about what ImPreP is, its activities, and definitely what to expect from its outputs. We are now describing, we will describe what ImPreP is, but in the near future, we hope to share with the public our findings and some other information that is relevant. We will also use this system, the NEMUS and publications and other knowledge sharing activities to share whatever we're learning with the public. So today we'll have the 3 PIs, and Valile is the lead PI and the Brazil PI, Hamid Vega, the PI for Mexico, and myself, the PI for Peru. So I will briefly present introduce the 3 of, not myself, the 2 of them, although I think they have been introduced before. But anyway, Valilea is director of the Evandro Chagas National Institute of Infectious Diseases at Fiocruz. She's a co-PI of the Fiocruz HIV/AIDS Clinical Trials Unit, ACTG, and HPTN co-investigator, and was a PI of the ImPreP study at Fiocruz and co-PI of PrEP Brazil. She's a member of the Brazilian Antiretroviral Advisory Committee, as well as of the PrEP Advisory Committee. She's a member of the UNAID Scientific and Technical Advisory Committee and has served on the Global Fund for HIV, Tuberculosis, and Malaria Technical Review Panel. Okay, she's Valilea. I will also introduce Hamid. He's a psychiatrist who graduated from the National Institute of Psychiatry Ramón de la Fuente Muñiz, doctoral student in public mental health at UNAM, coordinator of the mental health program of the Condesa and Condesa Iztapalapa specialized clinics. He's a member of the Technical Advisory Committee of HIV and STIs of PAHO, and together with his team, he's responsible for the clinical care and research of mental disorders in people with HIV and other sexual minorities in Mexico. He's the PI for ImPreP in Mexico. So, you have had me for, in all sessions, so I don't need to be introduced just for that. So anyway, Valilea, please, you can start. Thank you. Valilea, are you there? Okay, Miguel, hagamos a Valilea presentadora.
Ya le envié la solicitud, Carlos.
Okay. Val, you have to accept the invitation to share your screen. Val, we can't hear you. Are you there? Well, definitely we spoke with her before, so I think we should be able, we will be able to hear from her very soon. Galilea, we can't hear you. So please, can you check your mic? So apologies, we just double check with her. Anyway, I think, I don't know, Hamid, can we start with you?
Yes, sure.
Yeah, okay. So we'll just, okay, Miguel already made you the presenter, so please start and we'll check what happens with Galilea. Okay, please, you can, okay, great.
So I have to start my presentation, right?
Yeah, exactly. So, exactly.
Okay. Yes.
Okay. Okay, are you sharing your screen? You have to share your screen.
Can you see the presentation?
Yeah, we can see it. Yeah, we can see it. Yeah,
okay.
Sure.
Okay. Cool. Okay. So, okay. Oh my God. You can see my presentation, right?
Yeah, sure.
Okay. So, well, I'm going to be very brief in this presentation. I hope that Badilea could present all or most of the details of the project. My main objective of this presentation is to talk with you about some characteristics of this huge project here in Mexico. Well, as you know, and as Carlos said, this is a project between Brazil, Mexico, and Peru, and the lead country in this project is Brazil. But we have some differences in the implementation in the three countries because, as you well know, the three countries have different healthcare systems, so we have to adapt the demonstration project healthcare systems. In Mexico, I have to say we have different kind of healthcare services. We don't have just one as in Brazil. So the project will be supported and is very closely followed by the Ministry of Health here in Mexico and the National Program of HIV. So even though UNITAID established the fast-track targets, it is clear that there is a need to modify the prevention strategies that different countries currently use, because even we have a very good improvements in the increased condom use among youth people and the accessible and affordable treatment almost in all the countries. The prevention programs, I think they are partially successful. So if we want to reach the 90% of the HIV diagnosis, the first 90 in these populations or the most affected populations in the countries by the epidemic, the prevention can become a way of approaching and promoting diagnosis in these populations. This is the cascade or the continuum of care in Mexico City, the last inform that was launched by our national program of HIV. Sorry, it is in Spanish, but you can see the percentage of the targets that we have here in the country. So as you can see, only the 64% of people who are estimated with HIV in our know their status. That is that almost 40% of people don't know their status, and there is a high possibility of HIV transmission. Although we have good coverage of heart, as you can see, is almost 95%. The first 90 continues to represent an important challenge for our country. This is not a very good quality of the image, but in the first row, you can see the prevalence of HIV in Mexico City. That is that Mexico City has the highest HIV prevalence in the entire country, accounting almost the 25% of all cases. And this is one of the main reasons why we decided to implement this program or to lead this project, in the Condesa clinics, because the Condesa clinics concentrate the highest numbers related to HIV tests and persons on their heart. But as I said before, HIV diagnosis is still a big problem in our country, and Mexico City is not the exception. In some studies, it is described that the number of late heart initiators is high. And as you can see in this picture and this graphic, this is a cross-sectional study of almost 10,000 persons where other countries from Latin America and the Caribbean participated, and also Mexico City. They found that more than 70% were late initiators. This was defined as people who started heart with less than 200 CD4 account or had AIDS defining illness. Late testers, people who started heart within 6 months of HIV diagnosis, and late presenters were those who started the therapy after these 6 months of HIV diagnosis. So, as you can see, the percentage of these people, are very, very high. Another key population that it is difficult to promote prevention and diagnosis has been transgender women, also for us here in Mexico. And in this study, as you can see, we have a representative sample from Mexico City of transgender women, and you can see the high prevalence of HIV that is reaching almost the 50%. Something that I want to note about this study is the prevalence of HIV in the meeting places, where the largest number of young people was found. Them was engaged in sex work. But also, an unfortunate finding was that in this subgroup, only the 26% of trans women who were HIV positive knew their diagnosis. The rest of them didn't know their status. With all this background, it is not surprising to find that the prevalences of the different population managed at Condesa clinics are in the groups with the highest risk of acquiring HIV. As you can see in this table, the three main populations, the transgender women, the MSM, the male sex workers, represent almost the 90% of people with HIV in the clinic. And in the Condesa clinics, there have been an increasing come to be tested for HIV. In this graphic, you can see all the HIV tests that were performed on 2016. But this effort of increasing the person that come to get an HIV test has not been very easy. This is the result of HIV test promotion among key populations aligned with the provision of other healthcare services for each population. So as you can see in this slide, most of the men who came on 2016 to be tested are under 25 years old. And as you know, this is the group where the new infections usually occur. And that's why we want to promote the use of PrEP among these young men, very, very strong. But we have another problem here in our country. Not only having many people from populations is enough, we have to deal with other problems in the process of PrEP implementation. That is, as you can see in this table, the cost of sustained PrEP in Mexico would represent almost 90% of the cost of heart for people with HIV. And it is well known that the cost effectiveness of PrEP implementation strategies goes down if the cost of the drug is high. So in Mexico, we need to find a way to decrease the price of TDFFTC if we want to maintain sustainability for this prevention strategy. We know that we know that FDA has recently approved a generic TDF-FTC drug, but we don't know when it will be available in Mexico. So since PrEP is not yet available in Mexico, we were invited to participate in a demonstration project led by Brazil, as I said before, and also participate. And the main objective of this project is to assess the uptake, effectiveness, safety, and feasibility of PrEP in the context of combination prevention for HIV, public services, and non-governmental organizations. For the project, we have to enroll MSM and transgender women, the most affected population of HIV. So here in Mexico, there will be 8 implementation sites along 3 states in the country, Mexico City, Jalisco, and Oaxaca. And we are planning to enroll 3,000 participants. We decided to include these 3 states because they have the capacity to confirm negative results for the participants. In Mexico, for this project, we have a big donation from Gilead for the use of Truvada in order to use it in this project. I must also say that this project not be possible without the collaboration of different institutions and organizations. And even though the local Mexico City's HIV program will lead this effort, the national program has also participated since the very beginning, and also the UNFPA that is currently managing all the resources for this project. Also, other academic institutions and civil society organizations will collaborate very actively. Another important aspect to consider in the implementation of PrEP in Mexico is the message that we will give to the population and health professionals. We have found some resistance to start with this preventive strategy since it is thought that it will replace the use of condoms and there will be risk compensation on the sexual behavior. So that's why we will say that the persons that want to start PrEP always have to be tested for HIV and other STIs, and we would like to also give treatment for these infections also. And we also want to, if it's possible, to give or to promote another healthcare services according to the key population that we are approaching. So as you can see, or as you can think, we want to use the PrEP implementation of this project in order to insert this strategy to the other strategies that we currently use in the country. We want to combine, complete this puzzle in order to have a better combination prevention strategies in the country. I know that this project is going to be only in 3 states, but we hope that the results of the project could help to make some changes in health, in the health policies. So, in conclusions, in Mexico, combination prevention for HIV must include different strategies and the involvement of government, academic institutions, and civil society. The inclusion of PrEP programs in HIV health care facilities will increase the early detection and treatment in order to reduce the possibility of transmission. Increasing the diagnosis and early incorporation to health services is in primary healthcare facilities could reduce the community viral load. And prevention programs should consider the characteristics of the key populations with high and low HIV prevalence and should be accompanied by outreach and integration services. And finally, in the middle income countries like Mexico, demonstration projects are necessary to get valid and reliable information to help stakeholders in the making process to improve health policies. Finally, I also want to give some acknowledge for all the people that are very involved in this project. It's a very important project for us, and it's a project that a lot of people are involved in the development and in the implementation, as you can see. So, thank you very much.
Thank you very much, Hamid. I'm checking with Galilea. Apparently she has a technical problem and they are trying to solve it. Hopefully she will be able to connect, or at least she can send her presentation and we can show it from here while she speaks. So while that is resolved, I will just continue. So Miguel, please, por favor, hazme presentador a mí. Okay. Okay. So thank you very much again. And so I was not going to touch some topics, but since Galilea hasn't presented the first part, I may talk about some of the basics of the study, but definitely I will focus more on what is happening here. So what about prevention needs in Peru? Definitely MSM and transgender women continue to be at very high risk, with incidences of HIV between 4 and 6 infections per 100. Okay, that's Vanilea. So I think we can hear her now. Yeah, we can hear you. So let me I will continue while you get ready. Okay.
After you finish, I could try.
Okay, so just continue with that. Great. So in terms of problems we have here, condom use continues to fall, and that is a global trend. There are several active practices among people, but the magnitude of their use is still unknown. There's infrequent HIV testing, and that is the result of denial due to stigma, low access due to low use of public health facilities. They are not inviting services either. There are limited alternative options, and cost for testing is, in some cases, besides the public services, high. Barriers related to services and initiation of treatment are important as well. Delayed start, fear of side effects, stigma, etc. Limited grounding of the concept of combination prevention, and an unfavorable context towards the human rights of key populations. In terms of knowledge, attitudes, and practices, men who have sex with men and trans women show still low level of information about PrEP. Condoms are still the paradigm of prevention, although they are not used very frequently, with all the problems it implies. Trans women fear that PrEP will affect their feminization practices in some cases, and there's a certain level of opposition from activists towards PrEP that, I mean, it's clearly in reversion. It used to be more important, but definitely there in the past 2 years, there's a trend towards an increasing popularity of PrEP among MSM and trans women, and to a lesser extent among trans women, in part because they were not the focus of studies like ImPreP. There were a very limited number of trans women participating in ImPreP, as we all know. Only recently there are concrete efforts to study PrEP among trans women, and probably that will have an effect relatively soon. Among health providers, the level of information about PrEP has also been low until recently. So there's a need for theoretical knowledge and concrete skills for them to be able to offer PrEP. Previously, negative attitudes, as I said, are improving, and the Ministry of Health has expressed interest in incorporating PrEP. More than that, I will say, just as a timeline of the process of establishment of this study, we all know, I mean, the Ministry of Health knows that this study is being conducted only to help the public sector test to what extent this strategy can be incorporated within the public services, and for adaptation, it's really operations research. So we got their formal commitment in December 2016 to be open to the study. In Peru, the use of TDFFTC for preventive purposes was approved in April 2017. A specific MOU for institutional collaboration for this study was signed between the Ministry of Health and the university. The National AIDS Control Program is formally a counterpart of the study. There's specific coordination with each regional health division for this purpose. And definitely there will be benefits for them, like, I mean, supplementary equipment as a donation to eventually to the centers. Participating personnel will receive training with academic credit. Then in terms of public primary objectives, I will just address them, and Valeria will not need to go back to them. The study seeks to determine acceptance and use of daily PrEP among MSM and transgender women who are offered PrEP in the context of public health programs, determine differences in the acceptance and use of daily PrEP by sociodemographic characteristics and risk practices. So who is more willing to determine the differences in duration of PrEP use according to those characteristics, describe the frequency of side effects and toxicities, describe patterns and correlations of adherence to PrEP in participants of the demonstration cohort, measure changes in sexual risk behavior in participants of a PrEP demonstration cohort. So we'll look at many of these things, many of these aspects that in some cases have been a source of concern. For example, is there risk compensation? What happens with adherence, etc. Secondary objectives include an assessment of HIV incidence, then to assess the prevalence of HIV among people screened for HIV during the recruitment process, and determination of the incidence and patterns of resistance and antiretroviral use among men who become infected while participating in the demonstration project. Just to respond to Galilea, yes. When I finish my presentation, we will make you the presenter. So for the moment, since I am presenting, I'm the presenter. Inclusion criteria: male sex at birth, to be adult, to be HIV negative, willing and able to provide written informed consent, evidence of risk for acquiring HIV infection, including at least one of the following: so anal sex without a condom with a transgender man or woman during the last 6 months, anal sex with at least one HIV positive partner during the last 6 months, urethra or rectal gonorrhea or chlamydia or syphilis reported in the last 6 months prior to enrollment, to report transactional sex, and adequate renal function. Exclusion criteria: signs or symptoms of acute infection, pre-diagnosis of active and serious infection, important medical conditions, a history of fractures, the person is being treated with ARVs except for PrEP, interferon, agents that affect kidney function, concurrent participation in a clinical study with drugs, and other conditions that affect participation. In Peru, the study is going to be conducted in 10 sites in 6 cities. Now, in the Central Coast, we have Lima, Callao, with 5 centers, 4 public, and 1 is the only private site, the community center, and Pisco, the other city. In the Northern Coast, we have Trujillo, Chiclayo, and Chimbote, and in the Amazon, we have Pucallpa. So there are 9 services, public services, and 1 private service. The recruitment goal is 1,500, and recruitment will happen during 2018. We'll promote visits for prevention, and people will be screened there. So there will be campaign to promote people coming, and they will know that PrEP is one of the options there. Everybody will receive a preventive recommendation, and those who meet criteria for inclusion in the cohort will be invited to join the cohort, and if they accept, they will be screened. So some people will arrive via an HIV self-test, and of course they will be tested again. And at screening, the participant will be clinically evaluated, rapid HIV test will be performed, samples will be drawn for acute infection and other tests, and PrEP will be provisionally prescribed. This is the algorithm, for the study. There are a few things that keep changing, but as you see, there's a lot going on, and the idea is for people to know that this is combination prevention, and PrEP within the smaller frame is something that will be one of the options, and it's interconnected with the others. So our idea is that this is not just PrEP implementation. In a way, this is more the implementation of combination prevention. The follow-up period will be between from 2 years to 2.5 years until June 2020. The initial cohort visit, there will be a control visit after 1 month, and then quarterly visits where people will be tested for syphilis, HIV, syphilis, and renal function, and with less frequency, chlamydia and gonorrhea testing by PCR. No incentives will be given. This is not a clinical study. This is those who do not return will be followed to see the reasons. And just to end a few of the complementary studies, the formative study that is being conducted now with a qualitative component, checking for the procedures, validating study activities, and an online survey that is about to start, where we'll actually have a clear vision of our study population. Then we have communication strategies like this is another study, validation of the PrEP offering strategy in the framework of combination prevention and impact evaluation of communication activities among members of the target community. Then a very important zero incidence study that will validate that we're actually addressing the population we need to address. This is a population that is supposed to be a high risk population, and will confirm that we have a high incidence. Then the use of a modern version of sensitive, less sensitive assay. Then mathematical modeling, real versus estimated performance. That's something that will help us more in-depth assess how we're doing with the impact and the cost effectiveness. So we'll actually estimate as well what some of the things that the study is paying for will be how much they will cost to the government when they offer the program directly, and the study of health systems as well, identification of strategies to better adapt the program. Anyway, potential benefits to the country, strengthening the overall prevention strategies, an increase of the coverage, increased capacity to confront the epidemic among two groups that continue to show high incidence. In those groups, to improve awareness of the nature, role, and utilization of PrEP, identification of criteria for the administration of PrEP to be defined in a normative and programmatic framework, and the identification of criteria to strengthen the knowledge and skills of health teams in relation to combination prevention. So this is also in my last slide, just showing our team that they have to be acknowledged. Kélica, Oliver, Juan Vicente, Elizabeth, Gino, Jimena, Aaron, Silver, Miguel, Fernando, Cecilia, Jimena, Raúl, Sonia, and our community advisors and research site teams. Thank you very much. Then I'll stop here. And I'll check. I hope Valilea can already connect. Valilea, are you ready? We can make you the presenter now. ¿Podemos hacer presentadora Valilea? Okay. Valilea, are you there? Okay, at least this is Valilea's screen. So now we just have to listen to you. Valilea, we still can't hear you. Check your microphone, please. Great. Yeah, now we can hear you. Good.
Yes. Our screen is now shared?
Yeah, we can see your screen now. You can see.
Okay. Thank you.
You can put your PowerPoint in presentation mode.
Are you hear me?
Yes, we can hear you. Much better now.
Okay.
Yeah, good.
Okay.
Excellent.
So I would like to thank you, NEMUS and Carlos, for the opportunity to present the project and to discuss it with you. Our approach is the preparedness or rollout of effective HIV prevention among gay populations in Brazil, Peru, and Mexico. We have myself, Hamid, Carlos, and Hugo Gattel and Beatriz Greenstein as research leaders of this project. We planned this study because of the characteristic of epidemic in Latin America. That is a concentrated epidemic, mostly on MSM and transgender women that have high prevalence in an environment of persistent stigma and discrimination and poor access to services. As PrEP is now approving highly effective prevention intervention, it fits well for our context of AIDS epidemic. We have Brazil, Mexico, and Peru have large experience on provision of care, prevention services, and doing research on targeting men who have sex with men and transgender women. And we had the opportunity to Brazil and Mexico to conduct the ImPreP study that proved the efficacy of PrEP among MSM and transgender women, as well as the OLE study. And in Brazil, we have conducted the PrEP Brazil. Actually, the study is still ongoing. We have enrolled around 600 MSM and transgender women in 5 sites in Rio de Janeiro, São Paulo, Manaus, and Porto Alegre. And we are also conducting Preparadas, that is a PrEP study designed specifically for transgender women. It also includes a sub-study of drug interaction between hormones and PrEP drugs. And when we planned we submitted the project to UNITAID. PrEP was not a public health policy in any of the countries in Latin America or in any developing countries. And until 2017, access to PrEP was limited mostly to research projects, because although PrEP can be purchased in Brazil, Mexico, and Peru, it's only for people that have money to do it. In 2000 now, in 2007, late 2017, and actually access is happening now, Brazil incorporated PrEP as a public health policy, and it will be available in 33 health services. And we plan to, there is a narrow in this slide. And there was identified need, and still there is this need to generate evidence on PrEP specific for Brazil, Mexico, and Peru, health system and cultural environment to support government decision on PrEP incorporation. The project will be implemented in 10 cities in 6 cities, 10 sites, 6 cities in Peru, 8 sites in 5 cities in Mexico, and in Brazil it will happen in 15 sites in 12 cities in different regions of the country. The goal of the project is larger than a demonstration project. Então, our goal is to contribute to the reduction of HIV incidence among MSM and transgender women in Brazil, Mexico, and Peru through the inclusion of PrEP as a component of HIV combination prevention service. And the project outcome is to contribute to increase PrEP uptake among high-risk MSM and transgender women in Brazil, Mexico, and Peru, contributing to increase PrEP adoption globally. The project is funded by UNITAID and the governments of Brazil, Mexico, and Peru, in close partnership with the Ministry of Health and city departments in each country. And the project includes one PrEP demonstration study that will enroll 7,500 MSM and transgender women in Brazil, Mexico, and Peru. We will have some surveys, qualitative studies, epidemiologic and economic studies. And we will have a survey among MSM and transgender women in separate to assess PrEP awareness, willingness to use PrEP, HIV testing frequency and preference. Among physicians and healthcare providers, we will assess attitudes toward PrEPs and willingness to prescribe PrEP. Among stakeholders, we will conduct a qualitative study to assess knowledge and attitudes about PrEP of key program, HIV program and health service managers, and digital opinion leaders, and also NGO activists. We will have, as Carlos already said, that we will have a serum incidence study among the populations targeted by the demonstration study, and that will provide us data about incidence. For instance, if the government decide to use the same criteria we are using in our demonstration project, we will have the incidence that we have in each country for that specific population with the same criteria. And so it will guide us if we are really reaching out the among those MSM and transgender women, those that are in higher risk of acquiring HIV infection. We will have also some economic studies that and mathematical modeling that will include cost effectiveness, but not only it. It will support the government about the decision to incorporate PrEP as a public health policy. We also have in the project a strong component of community engagement and education, and demand creation for PrEP that will have full participation of the community. The demonstration study is a multi-site, prospective, open-label demonstration study that will assess uptake, acceptability, and feasibility of tenofovir and entricitabine orally once a day among MSM and transgender women. We will have 3,000 participants in Brazil, 3,000 in Mexico, and 1,500 in Peru. Each project sites will be established on public or community health services, including NGOs, ECT, STI, clinics, and PrEP services. All participants will receive comprehensive HIV prevention service. Uptake and adherence assessment will include self-report, pharmacy dispensation data, and as well as drug levels measurement using dry blood spots. Participants will be screened for sexually and treated for sexually transmitted infection. For the screening, we will use molecular biology. We will run PCR. The study drugs in Brazil are purchased and donated by the Ministry of Health. In Mexico donated by Gilead, and in Peru will be purchased by using project funds. And we are developing a regional exchange platform that will be in internet, that will facilitate the exchange of the project results and other important publication and other study results related to PrEP. We will have a working group on drug licensing and costing, and it will support the advocate for guidelines, policy review for PrEP science. So this is a brief presentation about the project, and we are available for questions.
Okay, we have limited just a few minutes for questions, but so please, if you have any question, use the chat window for that purpose. I would actually like to ask both. Yeah, Jan is saying congratulations, and I think there's a question there. Let me just check. Oh, Rosalind. Rosalind has a question. Rosalind Coleman. Did you ever consider TDF-3TC or the TD maleate or TD succinate for with FTC?
At least in Brazil, we are not considering to use 3TC because we prefer to rely on the evidence that is already generated, and the Ministry of Health is already purchasing the combination of tenofovir and emtricitabine, and we also have at least one Brazilian company that is already ready to register a generic version of Fuvaro. I don't know about Carlos and Hamid.
Yeah, in our case, definitely TDFFTC is available here, and TDF-3TC was not of much use before. There was not a strong reason to use it instead of TDF-FTC. So I guess it was just natural to consider TDF-FTC. There was also the possibility of accessing it at a relatively low price via PAHO. So it was not a reason for that. And the other drugs, we're talking more about the new versions being generated by Gilead. So I don't think, I mean, we are, this is a demonstration study, so we're using products that are already available. Now, in terms, there's another question from Shona about the feminization process among trans women as one of the concerns they had. Well, in fact, the concern they had was not about PrEP specifically, but about some kind of myth with regard to the use of antiretrovirals that I mean, would interfere with the feminization process because of lipodystrophy and some other changes that they don't, I mean, that they would hate to experience. But we're talking about lipodystrophy of the kind that old HIV drugs produce. We're not talking about the new, I mean, TDFFTC. So it's more of the mix of myths from various times and different processes, unfortunately. But that's, so in a way, it's just a discussion and just a process of learning, of negotiating with different groups to see how can be done, what can be done, how things can move forward. So in essence, it's that. I don't know if you want to, Hamid, or actually, Hamid, I didn't let you talk about the option of considering 3DF3TC or one of the other drugs. Do you want to add anything in that regard?
No, actually, no. The main reason to use TDFFTC was the same reason as Badilea said. We wanted to use the drug that is highly or very proved in the using of PrEP. So, and also because, oh well, obviously because we have this donation from Gilead, but also because we are planning to try to push the effort that our local drug regulatory agency try to approve the importation of the generic of TDFFTC in order to use it also. Obviously, this is only in a plan, but here in Mexico we have this community, well, this directive committee that has been made with all the actors that are very involved in this project in order to follow all the findings that we can report from this implementation project, since we don't have any experience in PrEP in the country. So this directive committee or this steering committee is the members are actors or stakeholders that could have some influence in the decision of some kind of changes in the health care policies in the country. So that's the main reason.
And there's one question that is very important from Yanis. My question is the following: do you think through this study we have the opportunity to showcase added value of screening for bacterial STIs? There seems to be outstanding questions whether we should screen for STIs more frequently, every 3 months versus every 6 months in PrEP users. It would be nice to hear our perspective. I don't know, what do you think, Valdilea, Hamid? I mean, but, well, Brazil is in a special position in this study since they have already conducted a previous demonstration study, I mean, until last year. So it's they have fresh information for the Brazil case that is useful for this study, and I think Valdilea can share a bit about that. So what do you think about the convenience of testing for or screening for STIs more frequently? What do you think?
In the context of PrEP, the screening for STIs is even more important. And we will, with the project, we hope to generate this data and to demonstrate that it's a need to have molecular biology available at least on sites where PrEP will be available. And so I know that the cost is very high when we think in implementing it for the whole country, for the whole population. But at least maybe the Ministry of Health, with our data, may decide to start to implement molecular biology for diagnosis of STI, starting through PrEP sites. I would like to comment on the issue of the transgender women. They are concerned about the interactions between hormones and antiretrovirals, and it's why not in PrEP, but here at Fiocruz we are conducting Preparadas, that is PrEP project targeting transgender women. And we will do a sub-study of drug interaction between tenofovir, emtricitabine, and hormones used for feminization. So we believe that it will help to decrease the concerns that a transgender woman have with using PrEP.
Yeah, I think, thank you, Vadile. I think it's a very good point. The issue is that it's not, with regard to transgender women, their concern came from before and is not necessarily related to the concerns that emerged, have emerged over the last few years about, estrogen and hormones with regard to PrEP. So, of course, within the research community, that was a concern that emerged, that this had to be taken into consideration with regard to use of PrEP among trans women. No? But the concern they had was unrelated to that technical issue. It came from before and about lipodystrophia. 20 years old. But definitely that's the two things in a way end up being have to be taken into account together. Now, just one last thing to add to what Valeria said. Definitely, you may know that while syphilis testing is quite inexpensive, the PCR, so molecular testing for chlamydia and gonorrhea, is much more costly, and that is one big barrier for health facilities across the world, mainly lower and middle income countries, to implement these tests more often, because it's not just the machine. In any event, the machine, which is also used for public TV programs, could be the same machine could be used, but the kits are very expensive. So hopefully those kits will be more accessible. That would make testing much easier. And among MSM and trans women, the issue is mainly not urethra, because urethra is much more often symptomatic. It's more about the often silent, asymptomatic anal infections. And that is something that would really benefit from our ability to test for these diseases more often through anal swabs. So anyway, I think there's no more.
Carlos, and we will have the data about the about STIs, and maybe we can use it to do also economic study about STI diagnosis screening in the context of PrEP.
Yeah, that would be very important. That would be very useful. Okay, anyway, I think we are 5 minutes past the hour and we have to stop here. So anyway, as we said, we will have a presentation in Portuguese and Spanish on Thursday, 2 days after today, the same time. And for the time being, I just have to thank everybody. We've recorded this presentation and will, as usual, upload it to YouTube and in our website, and it will be able to be shared as well. So thanks a lot to all participants, all people who attended, and of course, thank you very much, Valilea and Hamid and Miguel, for your support. So we'll keep in touch with an exciting, probably next month, we're going to be able to complete the series of WHO, the presentations about the WHO implementation tool as well. So thank you very much. Thank you all, and we keep in touch. Bye.
Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.